Rapid 2023. The topic we are going to discuss today is hyponatremia, which is a disorder of water metabolism. In hypokalemia, that is a disorder of potassium metabolism, hypoglycemia, that is decrease in glucose, but hyponatremia on the other hand has nothing to do with sodium. It is basically a disorder of water metabolism, or in other words, hyponatremia is water excess. In this module, we are going to discuss today is the basic concepts of renal system and the basics of hyponatremia, the symptoms, the investigations, and finally the treatment of hyponatremia. So, coming to some basic concepts, we have to identify the difference between effective solutes and ineffective solutes. Effective solutes, for example, glucose, mannitol, glycine, and maltose. These are substances that increases the osmolarity and decreases serum sodium. Whereas ineffective solutes are those substances, for example, urea, ethanol, and methanol, that increases the osmolarity without changing the serum sodium. So, the basic difference between ineffective solutes and effective solutes is that in ineffective solutes, the osmolarity increases and the solutes move from a region of higher concentration to lower concentration, that is from blood to the cell. That is, when urea, ethanol, and methanol, when increases in the blood, that increases the osmolarity of the blood, and in turn, the solutes will move from a region of higher concentration, that is blood, to the region of lower concentration, that is to the cell. Whereas effective solutes are those substances that increases the osmolarity and decreases serum sodium, because in glucose, mannitol, glycine, and maltose, those substances cannot process the cell. So they lie inside the blood, thus increases the osmolarity. So at a particular point, the water concentration will increases inside the cell and water will move from a region of higher concentration, that is from the cell to the blood. That indirectly causes hyponatremia. This is called translocational hyponatremia. Therefore, tonicity is equal to effective serum osmolarity. So, effective serum osmolarity or tonicity is the concentration of solutes that do not crosses the cell membrane. That is, osmolarity that is due to effective solutes. The serum osmolarity formula is 2 into serum sodium plus blood glucose divided by 18 plus blood urea nitrogen divided by 2.8 or urea divided by 5.6. Therefore, the major intracellular cation that helps in maintaining this osmolarity is the serum sodium. So the points to be noted are hyponatremia is equal to hypotonicity. So a true hyponatremia means hypotonicity and hyponatremia. Whereas hyponatremia that is associated with normal or increased tonicity is pseudo-hyponatremia or translocational hyponatremia, which we studied previously in the cases of glucose. Now we come to the parts of a nephron. The nephron contains the afferent arteriole, the glomerulus, and the efferent arteriole. Then comes the Bowman's capsule, the proximal convoluted tubule, the descending and ascending loop of Henle, and finally the DCT and the collecting duct. Then we come to the basic renal processes, that is filtration, reabsorption, secretion, and excretion. Filtration means the shift of fluid from glomerulus to the PCT. Reabsorption means the movement of this fluid from PCT to the peritubular capillaries, whereas secretion means the movement from peritubular capillaries to the tubules. And finally, excretion is filtration minus resorption plus secretion. Then we come to water absorption. The water absorption that takes place inside the PCT. There are two types of water resorption. That is obligatory water resorption and facultative water resorption. Obligatory water resorption is not under any hormonal control, whereas facultative water resorption is under ADH. The water resorption that takes place inside the PCT is the obligatory water resorption, and it is also isotonic water resorption. That is, water and sodium are absorbed in equal amounts. The resorption of sodium, water, potassium, calcium, phosphate and bicarbonate, glucose and amino acids takes place inside the PCT. So equal amount of sodium and water are resorbed, and this is not under any hormonal control. Therefore, it is an example of obligatory water resorption. Then we come to the loop of Henle. So, from the glomerulus, the loop of Henle receives isotonic fluid from the PCT, having an osmolarity of 300 milliosmol per liter. The descending loop of Henle is permeable to water and impermeable to electrolytes. The descending loop of Henle is therefore called the concentrating segment or the countercurrent multiplier, whereas the ascending loop of Henle is permeable to solutes, whereas impermeable to water. The furosemide or the loop diuretics inhibits the sodium channel excretion. Coming to the DCT. In the DCT, the sodium chloride co-transporter in the DCT causes sodium and chloride resorption. This is blocked by thiazide diuretics, thus causing sodium excretion in the urine. Coming to JJ apparatus. JJ cells are the granules that releases the urine. And now we come to the mechanism of activation of RAS. Whenever there is a decrease in sodium, that is hyponatremia, or where there is a decrease in BP or hypotension, the JJ cells that are present inside the afferent arteriole will release the renin. Thus, there is an increase in renin production. The angiotensinogen that is produced in the liver is converted to angiotensinogen 1. The ACE enzyme will convert this angiotensinogen 1 to angiotensinogen 2. And this angiotensinogen 2 causes increase in BP by vasoconstriction. The angiotensinogen 2 also releases aldosterone that increases sodium resorption. So finally, what we have to take is the hyponatremia and hypotension are the triggers of release of renin. And the final effect is increase in BP and increase in sodium resorption. Then we come to the collecting duct. In the collecting duct, there are two main hormones that act. One is aldosterone and antidiuretic hormone or vasopressin. The resorption of sodium and water and excretion of K plus and H plus are initiated by aldosterone. ADH, where on the other hand, causes exclusively water resorption. So, coming to the action of aldosterone. Aldosterone will act on P cells and I cells of the collecting duct. In the P cells, it causes sodium and water resorption and K plus excretion, whereas on the I cells it causes K plus resorption and H plus excretion. Coming to ADH and vasopressin. ADH or vasopressin acts at the collecting duct and exclusively causes water resorption. So, coming to some of the basic concepts of ADH. So, looking at this diagram, whenever there is a low tonicity or a low effective osmolarity or hyponatremia, the ADH will not act. Whenever there is an increase in osmolarity, there is an increase in ADH secretion. Therefore, increased tonicity, the ADH and thirst come into play. So the first mechanism that acts whenever there is an increase in tonicity or increase in plasma osmolarity is the ADH. At around 280 osmolarity, the ADH will come into act. Whereas around 290, the thirst mechanism will come into act. So the first mechanism that responds to increase in tonicity is the ADH. Now we come to the countercurrent mechanism. So in the countercurrent mechanism, the osmolarity at the DCT is 100 and the final urine that is passed is at around 80 to 900. The mechanism that helps in concentrating the urine is called the countercurrent exchange mechanism. The medullary interstitial osmolarity, that is a high medullary interstitial osmolarity, will prevent the movement of water from interstitium to the lumen. That is the main factor that is responsible for this countercurrent exchange mechanism that helps in maintaining the osmolarity at DCT at 100 and the final urine pass is around 900. The key factor that helps in maintaining the high medullary interstitial osmolarity is the urea by the vasa recta. Only when there is a high medullary interstitial osmolarity is preserved, the ADH can bind and the water can resorb. So the take-home message is that to maintain a countercurrent exchange mechanism, that is to maintain a concentrated urine that's to be passed, the key factors are: one, we need to maintain a high medullary interstitial osmolarity. Two, in order to maintain a high medullary interstitial osmolarity, the key factor that is urea. And finally, only when this high medullary osmolarity is maintained, the ADH can bind and the water gets resolved. Coming to medullary osmolarity, sodium that is coming out through the ascending loop of LE will accumulate at the tip of medulla. That in turn causes hyperosmolarity, and that is required for the ADH to act on the duct for water resorption. So a high medullary interstitial osmolarity is required for the binding of ADH, and that in turn causes water resorption. So why a normal person do not develop hyponatremia? It is basically due to three reasons. One, there is minimal ADH that is present in the resting state. We see the previous diagram. Only when there is an increase in tonicity or an increase in osmolarity at around 280, the first mechanism, that is ADH, will come into play. At the resting state or the normal osmolarity, the ADH is very, very minimal. Second, the resorption that takes place inside the PCT is iso-osmotic reabsorption. That is, equal amount of water and sodium is absorbed. The third reason is that the thick ascending loop of LE and the DCT will reabsorb solutes, and therefore the excretes water that is electrolyte free. So these three mechanisms will maintain or prevent our body from hyponatremia. Now we come to hyponatremia. Hyponatremia, it is classified basically into mild, moderate, severe and very severe hyponatremia based on the serum sodium concentration. Mild is around 130 to 134, moderate 120 to 129, severe 100 to 190, and very severe is less than 100. Coming to the symptoms that is related to mild, moderate, severe and very severe hyponatremia. In mild hyponatremia, only GI symptoms like anorexia, nausea and vomiting will be seen. Whereas in moderate hyponatremia, there will be predominantly GI symptoms plus a mild headache and lethargy. Coming to severe hyponatremia, it is characterized by neurological symptoms, that is, gait ataxia, disorientation, and confusion. In very severe hyponatremia, the features are raised ICT, stupor, coma, pseudobulbar palsy, and death. The important take-home message from this slide is whenever you see a serum sodium level, you have to correlate it with the corresponding symptoms. That is, a serum sodium level of 120 will never cause us severe neurological symptoms like seizures. So we need to compare the serum sodium level with corresponding clinical features that corresponds to the corresponding serum sodium level. Now we come to the types of hyponatremia. First one is hypervolemic hyponatremia. This is due to pooling of blood in the extravascular system, and therefore the intravascular volume is depleted. And when the intravascular volume is depleted, this activates the RAS. And we learned previously when the RAS is activated and ADH is also produced, that leads to water and sodium resorption. The examples of hypovolemic hyponatremia are cardiac failure and cirrhosis. Now we come to hypovolemic hyponatremia, where there is loss of volume from the system. It can be due to renal loss, GI loss, or third space loss. The examples of renal loss are tubular injury and aldosterone, whereas GI loss, vomiting and diarrhea. The third space loss is by pancreatitis and burns. The specific signs of hypovolemia are postural hypertension, skin tighter, tachycardia, and decreased urine output. And finally, we come to euvolemic hyponatremia. In euvolemic hyponatremia, you need to first rule out the correctable hyponatremia. The examples of euvolemic hyponatremia are hypothyroidism, hypocortisolism, and finally SIADH. Initially, we have to send a TFT, serum cortisol, and if both comes normal, then only you have to think about SIADH. In euvolemic hyponatremia, there is excess water, and in view of this, atrial natriuretic factor is increased and RAS is inhibited. That leads to low aldosterone, that in turn leads to low salt and water retention, that increases high urine sodium. Coming to the diagnostic criteria of SIADH, the essential diagnostic features are decreased serum osmolarity, urine osmolarity more than 100 milliosmol per kilogram in the setting of serum hypotonicity, euvolemic hyponatremia on clinical examination, and urine sodium more than 40, and a normal thyroid, adrenal, renal, and cardiac function, and no recent use of diuretics. This is the diagnostic criteria for SIADH. Now we come to the management of hyponatremia. The first point we have to keep is we have to divide, is the hyponatremia acute or chronic? Acute hyponatremia, the symptom onset is within 48 hours. The water that moves from cell to the blood due to the difference in concentration gradient, and that leads to swelling, cerebral edema, coding, and death. Whereas in chronic hyponatremia, the symptom is more than 48 hours. And at this point, the brain gets into its compensatory phase and it excretes solutes into the CSF. And as a result of which, there is an increase in water concentration inside the brain cells, thus shifting water from the brain cell to the blood. Coming to the management or treatment of hyponatremia. things we have to remember in hyponatremia is 1 liter of 3% hypotonic saline is equal to 513 milliequivalents of saline, and it corrects the sodium by 11 milliequivalents. The amount of sodium correction is given by 1 liter of fluid is calculated using the formula that is infusate sodium minus serum sodium divided by total body water plus 1. The key points to consider in the treatment of hyponatremia is that the fluctuation of sodium levels over 24 hours will lead to predisposes to osmotic demyelination syndrome. Our aim is to prevent cerebral edema. If 1 liter of normal saline is used, hyponatremia worsens as half of the saline corrects the hyponatremia and the other half is absorbed by the tissue as free water. So, coming to management of acute symptomatic hyponatremia, that is hyponatremia that presents within the 48 hours and there is severe manifestations of hyponatremia. We can give 100 ml 3% hypotonic saline each over 10 minutes. The guideline says we can even repeat up to 3 bottles. By giving 300 ml of 3% hypotonic saline, it will correct 3 to 4 milliequivalents of sodium correction within half an hour, which is sufficient. Repeat this regimen on day 2 if the patient is still showing symptoms on day 2. Our target is to get over the first 48 hours by avoiding cerebral edema and its symptoms. The only indication to repeat this regimen on the same day, despite the infusion of first 3 bottle, is continuous seizures. So, in acute setting of hyponatremia, that is the patient present to the casualty with severe neurological symptoms within 48 hours, then our management will be, we have to give 100 ml of 3% saline over 10 minutes. We can give up to 3 bottles and stop for that. The only indication to continue giving 3% saline is continuous seizures. That is the management of acute hyponatremia. Whereas coming to chronic hyponatremia, here the patient presents after 48 hours. So the time of symptom onset is unknown and we consider this as chronic hyponatremia. In the setting of chronic hyponatremia, we have to check for seizures. If the seizures are present, that indicates there is no compensation that has taken place and we need to consider it as acute hyponatremia. Whereas if seizures are absent, we need to check the sodium levels, and if the sodium is more than 120, we will look for the hydration status, and if the sodium is less than 120, we will look for the neurological symptoms. So basically, if we will look at the sodium status if seizures are absent. So if the sodium is more than 120, we look at the hydration status, that is, we can look at the IVC. If the IVC is collapsible and there is signs of dehydration, this will point towards hypovolemic hyponatremia. In this setting, we need to start the patient on 0.9% NS till IVC is well appreciated. Whereas in hypervolemic hyponatremia, we need to start the patient on diuretics and salt restriction, and Vaptans can also be given. Whereas if we are seeing only a euvolemic hyponatremia with no major neurological symptoms, we have to think about SIADH, and the management is fluid restriction and Vaptans. But if the sodium is less than 120 and neurological symptoms are present, then we need to start the patient on 3% hypotonic saline around the clock. So, the management of chronic hyponatremia, first thing we have to look at the presence or absence of seizures. If the seizures are present, it indicates there is no compensation that has taken place. and we need to consider it as acute hyponatremia. Whereas if the seizures are absent, we need to look at the sodium levels. If the sodium is more than 120, you will look for the hydration status and classify it as euvolemic, hypovolemic, and hypovolemic hyponatremia. In euvolemic, we have to take the TFT, the cortisol level, and if it's normal, you will consider SIAH. The management is fluid restriction and Watkins. Whereas hypovolemic hyponatremia, that is seen in cardiac failure and cirrhosis, the management is diuretics and salt restriction. Watkins can also be given. Whereas in hypovolemic hyponatremia, we will look at the IVC diameter, which is collapsible, and the signs of dehydration. And once we confirm hypovolemic hyponatremia, we start the person on 0.9% NS till IVC is well appreciated. So this is the basic management of hyponatremia. So in this module, we discuss the basic concepts of hyponatremia, the clinical presentations, the investigations, the types of hyponatremia, and finally the management of hyponatremia by classifying it as acute and chronic. Thank you.